Welcome to the Nurse Dad Podcast.
Hello, ladies and gents. I'm RN Glenn, aka Nurse Dad, host of the Nurse Dad Podcast. I'm a former Navy hospital corpsman, current ER nurse, and I'm actually now a nurse in the home health space via hospitality. And I'm here with Scott. Thanks for coming on, man. I really appreciate it.
Yeah, no sweat. I'm glad we were able to make it work.
I'm kind of rusty. I got sick all of December. It took some doing to even get this started. Then I woke up under the weather. Everything's going against me today.
That's what happens when you pick up a swing shift.
Yeah, I did that yesterday. Yeah, swing shift. I love them. I love the swing shift. You get home later, but those extra few hours, not having to wake up at 5 in the morning.
Yeah.
You were doing deadlifts before this. You don't really care about losing weight. You're talking more about toning. I always say weight loss is the wrong way to look at it. It's about toning muscle, because if you tone muscle, you're going to burn fat, but you're also going to put your body to work more, even when you're not working out, because you're going to create those micro tears in the muscles, and your body's going to be healing when you're not even working out, burning calories. Whereas weight loss is a little bit different mindset.
Weight is your gravitational attraction to the center of the earth, right? So it's a loose indicator. What really body fat percentage is what people should be measuring. What they mean when they say weight, oh, I'm going to lose some weight, they really mean body fat and tone out, like you're saying.
When I was in the military, that was the biggest thing. It is like a meme, like if you're built, you're considered fat, and if you're skinny, you're considered athletic. If you're a certain height, this is what your weight is.
Sure.
I was 6'2", 235 pounds. At the time, I was 12 or 13% body fat, but you have to get taped, because if you just go on weight to height, you failed your exam.
It's usually a good thing when they bust out the tape measure, because
it is a good thing.
Doing something good.
I'm not dissing GLP-1s. They work for a lot of people, but that's not the route you want to take.
So I'm good at bulking. And part of that is due to my...
Yeah, so I'm really good at bulking.
Especially around the holidays, right? But no, I'm not interested in the GLP-1s. I actually they're called bioactive peptides, but it really comes down to managing hunger suppression and making yourself more aware of, hey, my stomach's saying I'm full. Your eyes and your mouth still want to eat, but the GLP-1s, the big concern there is because most people lose a lot of weight very quickly. But
but also muscle, right?
Muscle and connective tissue, I've been reading. So that scares me, and I'm trying to protect my gains. So why would I do that? I don't want to sabotage what I've worked. You build that up over years. So
I used to be so good with the diet and exercise, and I feel like ever since 5 years ago I started having kids, bad habits have accumulated. For example, I could be good the whole day, and then at like midnight, I'm suddenly like, I've been good all day. It's the worst. It's not even bad, but just when you're trying to lose weight and you're counting every pound, just having a midnight snack and that insulin spike really screws you up.
Yeah, I keep cottage cheese in the fridge for that, because I get hit with that too, that craving at midnight. And
that's a good idea.
I'm like, okay, I try to relegate it to what protein do we have? So it's usually either going to be cottage cheese or limited peanut butter. And then I try to go back to sleep, so I'm not having this big meal at midnight.
Yeah, it started off like making grilled cheese for the kids, and then they eat most of it, and there's a little bit on the plate, and
You're playing at a harder level, though, because I don't have kids. I don't have kids yet. When you're doing that, you're making the grilled cheese, and it's starting to smell good and everything.
I know.
Yep.
It's tough. I never had snacks in the cabinet until 40 years old, pretty much. I'm okay with it. I'm a lot better than a lot of people, but I know we've talked about getting down to even below 20% body fat.
Yeah.
When you have goals like that, you have to be pretty strict.
Yeah.
I want to ask you how you got into nursing. How old are you, may I ask?
I think we're about the same age. I just turned 40.
Okay. You look good, man. You look good.
Well, likewise. So I got into nursing. I was daisy chained into it. I was actually in the service too. I was in the Navy.
How come you never told me this?
Because I wanted to be a surprise for your podcast.
All right. I'm very surprised. You said hoo-yah before. I was like, oh, that's nice of him. But fellow sailor, hoo-yah.
Hoo-yah.
I was a corpsman, so like hoo-yah and oorah. I got the best of both worlds. But what was your job in the Navy or Raid?
So here's the story. My dad was in the Marine Corps, right? So I wanted to be a Navy corpsman. Because they don't have their own medical unit, which a lot of people don't know.
I learned that at boot camp.
Oh, okay.
They're like, you're just going on a ship, bud. You could go with the Marine Corps.
All right, cool. Post. So I joined the Navy for that reason, and it didn't happen actually. So I had a good ASVAB. I'm colorblind, so I could have been a nuke, could have
Okay.
done anything except no electronics, no nuke, no anything that involves color. And I was told, recruiter horror story, hey, just go in boot camp. They'll give you they'll fix your paperwork. Go in undesignated. Big mistake.
My recruiter lied to me
Yep,
about
yep.
as a big, yeah. Okay.
So I'm like, okay, cool. It's not in the paperwork. Go through MEPS, get to basic. The third week, I think you can redesignate in basic, but they're like, sorry, the rate's locked up. And I'm like, cool. So I ended up being an undesignated first division on actually the last Spruance class destroyer in the Navy. So I decommissioned that and then went to another one. But I drove the ship, all the stereotypical stuff you imagine sailors doing.
Like chip and paint,
yeah, sand prime
all the
paint,
dirty jobs,
all of that, all the hauling, all of that. Yeah, that we were outside of the skin of the ship a lot.
But you're undesignated, so you don't have the same structure. Like you can't pick up petty officer
Until you strike.
Yeah. And were you able to get a rate?
No. So what happened was because I decommissioned that ship, they're basically like, we can give you corpsman now, but you're gonna have to add 2 years to your contract or early out. So I was like, nah, you messed up. I'm out. So after I decommissioned that ship, I just gotten out and then went to school.
All right.
Yeah.
Did you use the GI Bill?
Yeah.
Did you use the Yellow Ribbon program, or you didn't have to?
That, unless it goes by another name that wasn't available. But
okay.
But I'm from Illinois, and we had the Illinois Veterans Grant, which pays tuition.
That makes sense.
So I think at the time it was only Texas and Illinois that had any kind of tuition assistance on top of the GI Bill, which a lot of people don't know. And this was true when I was in. I don't know if you were in. You have to pay in to the GI Bill your first year. They do a deduction. It's a very well-known benefit, but a lot of people don't know we pay into the GI Bill our first year, which the return on investment in that is crazy. But
yeah, it is.
But yeah. Did I answer your question? I feel like I went on a tangent.
No, you didn't. Fellow sailor. That's amazing. It makes sense, though, a little bit, knowing a little bit more of your personality now. Navy personnel, I find we're like the most stubborn branch department in the military.
Yeah,
it's a very independent minded, they always joke like we have beer drinking in our song. It's just a very, I do what I want.
There's a reason they're called sea stories, right?
Yeah. So you were undesignated the whole time.
Yeah.
And but you had a good experience though. There wasn't any. Nobody was screwing around.
Good experience.
Higher ups.
Yeah, for the most part, with an undesignated ship, they don't want to send you personnel because you're decommissioning, right? So it'd be like 18-hour work days for weeks on end. But our home port was Japan, so Yokosuka, Japan. I got to see South Korea, China, Russia, do a lot of stuff. But
that's great.
But it was nonstop work. The long shift for sleep was 6 hours. Most of the time, you only got 4. So it was like work, but I've got to see a lot too.
The funniest undesignated story I ever heard, and then we'll move on, was I met this vet, and he was actually a nurse at the hospital, one of the hospitals I worked at. And he went to Hawaii as an undesignated sailor. He didn't have a chief. He didn't have the normal structure. And the Marines swallowed him up, and they trained him to be a corpsman. And the corpsman there trained him up, and he deployed several times to Iraq.
Go to corps school?
No corps school. He couldn't pick up any higher than E3. He did 4 years of that, and I think he went twice to Iraq. And just Marines are like, we'll take you and train you up. And the sailors there obviously took him in, and the corpsmen there. They always need help. And that was his story. He couldn't get his FMF pin, couldn't pick up E4, but he was there. He loved his Marines. He was very competent. He's a great nurse. So this is fun.
I would have taken that if they offered, but that's okay.
You're going into nursing. Was it this lingering desire you had to be a corpsman originally that just carried over into the civilian world?
Yeah, absolutely. That was part of it. My entire family, we're all military. All of my uncles on both sides, actually 3 out of 4 grandparents. My grandmother was a wave officer in World War II. So like
cool.
Huge military lineage. So there was that motivation. And then I'm good with people and I'm good with science. Nursing is a good fit for that.
Yeah, I always had a 99 or 100 average in biology back in the day.
Yeah.
And
it's interesting. It's fun.
Yeah, it was. And what's great about medical is it comes back to you. The more you learn about the human body, the more you're learning about yourself.
Yeah.
It definitely has changed my mindset in many ways and how I'm a parent to my kids. And so what's your specialty? Are you a home health nurse?
Yeah, now I am. So I've done a lot. I've done a lot mostly in the hospitals. I've worked in 14 different hospitals in 8 different states.
Okay.
And
I'm similar to that, not state-wise, but even now I work at several hospitals at once.
okay, right now I'm a full-time home health nurse, but my hospital stuff was more PCU, ICU, step down, emergency, trauma transplant. I bounced around to everywhere that's not like mother baby or pediatrics, which we did pediatrics in the emergency department, but outside of not really. So that's
That was a specialty.
yeah. And right now I'm doing just full-time home health, doing case management, and then but it's a lot of field work. So when I say case management, I'm still in the field 5 days a week, seeing patients.
Okay. I've looked into home health, looking for that golden contract. It appeals to anyone who was a corpsman or just anyone with that mindset like you have. I would imagine in the field, you don't want bureaucracy behind you or anyone directly telling you what you need to do, that you're just you, your knowledge and your wits.
And if you get the job done, they leave you alone generally. We still, every place, anywhere anyone works has BS, but yeah, exactly what you just said.
Is yours like a 5-shift a week, 8, 5/8, or how does that work? Because that's one of the things I didn't like about
I'm
it.
salaried.
I couldn't maintain 3/12. Oh, you salaried?
Salaried.
Okay.
I'm salaried, which it can be a good thing and a bad thing. They still measure productivity points. And this is going to sound low, but I see about 5 patients a day, unless it's a specialized visit. In home health, we call our admissions starts of care, and those visits can take anywhere from an hour and a half up to 4 hours. Was probably my longest one. Usually when they discharge from the hospital, drops the ball, that's when you have, oh, we don't have orders for any of these wounds. They don't have any supplies. So you're going in, you got to fix all that.
No, 5 sounds like a lot because you're traveling. Sometimes you're encountering a new place. You have intros. And then, of course, it's like, what's not happening to you? You have to call back. Like you just said, they don't have, this isn't happening. Or we have to escalate this. That makes a lot of sense. That definitely takes up the day.
Yeah, yeah.
What is it, 8 hours typically, or 10, or?
No, it's usually under. Okay, so if you're counting charting, my area that I go is the projects in the hood mostly. So you don't want to be hanging out with the bed bugs and the cockroaches and all that fun stuff too long. So if there's charting I can do outside of the visit, you go in, you do your vitals, you do your wound care, you do the mandatory stuff, but the little things I'll be asking, like, do you wear glasses? All the little forms we need to fill out. I'll be doing the verbal while I'm doing my physical assessment and so on, so that I can chart that outside of the visits. If I take that home, usually I'm charting for an hour or 2 after I get back. So it ends up being about 8 hours.
That's something to underestimate. When I was in nursing school, I had community health. It was Philadelphia. And I went into those impoverished communities, and it's stunning, not just from what real poverty looks like, multiple uses of an oven.
Yeah.
A lot of the places were quite filthy. I couldn't sit anywhere. There were visible cockroaches. There was visible droppings. There was visible mold. It's not good to breathe in it. You don't want to touch anything. It's quite tricky. So I can imagine what some of the things.
My go bag, I actually have an S hook that fits over a standard door, so I don't have to set my bag down anywhere if it's really bad.
See, little things like that. You would have to talk to someone in your position to even think of something like that. Are there other tricks that you use to try to maintain your own cleanliness?
Sure.
You have to go back in your car, you track some stuff home.
Sure.
What are some tricks that you've developed?
So I have actually a patient who can't get rid of his bed bug infestation, which I know is like a buzzword, right, for the nurses.
Oh, yeah, in ED, I would rather have MRSA, COVID, C. diff than a patient with bed bugs.
Oh,
that is the worst.
So prevention is the best medicine, right? I will see that patient last, so I'm not risking transmission between, if I know they haven't been able to get rid of them, I'll see them last in it, but
not to cut you off, that's an interesting triage.
Yeah.
Because we're not talking about acuity of illness. We're talking about I might, in a worst case scenario, be transferring bed bugs from one home to another.
Right. So I'll try to prevent that, because when they're impoverished like that, they don't have the resources to be able to rid themselves of it sometimes. Or they're, I don't want to say geriatric, but up in age where maybe they're not seeing them and they're not going to be able to catch that. So I do that, but I know you're familiar with the emergency department decontamination process. So I have my own version of that where and I actually did a video on this. It's up on YouTube because it's a long form video, but I will come home When I come out of the patient's house, I'll blast my footies because I'll have footies on and PPE. I'll blast it up. That goes into a bag. I have a specific cleaning protocol. I come home. My shoes immediately go into the bleach trays I have sitting in the garage. Those come out to dry. I strip, jump in the shower, and then it goes into a hot washing machine. So that's a brief synopsis, but I have the protocol for that too.
I'm really glad we got into that. That's the stuff that's very interesting to me. And I remember in Queens at the height of COVID, I lived in an apartment with my wife, and why can't I talk? What is the word?
Decontamination process?
Yes, that was to take off all my clothes except for my underwear, put in the garbage bag, but outside the door, like
Hey,
in
that
the
works.
ladder well area, like hope no one's walking up here. Especially at that time when you didn't know how bad COVID was, and my wife was pregnant and then had her newborn.
Yeah.
I don't care. You're gonna see me. You're gonna see my. You see me in
Free
my underwear. I
show.
don't care.
Free
I
show.
am not going in this apartment. There was a trick I learned from the Navy when I was on deployment with the Marines, and we were on a ship. It was a Marine Expeditionary Unit, so we did operations and training on and off the ship, but attached to a Marine unit. We would give all of our clothes, and people would take these bags and wash them. And I remember, to wash that much clothing, they used cold water. Essentially, they weren't going to waste hot water on uniforms like that. And sometimes they were bunched together so tightly that you have one uniform in one bag, and then you have hundreds of uniforms together in a huge bag, and each one individually compressed. So it wasn't really like the surface area wasn't getting washed well, and the water was cold. So during COVID, they were offering to wash our scrubs for us in the ER. This is what I'm getting to. But I never let them wash my clothes. I said, I'm going to bring my clothes home. I'm going to wash them individually in hot water and know that they're actually getting clean. So there was just like little things like that.
Yeah, I wouldn't trust them to do that because they told us that those little surgical masks, the efficacy's gone after 30 minutes and it gets moist. They said we could use that all day and then reuse it for an entire week. So I'm like, if that's their standard now, I wouldn't let them wash my clothes.
We had one mask for a week at a time, the N95s at one point, a week.
Yeah.
They gave you a bag and you put it in your locker and then you would use it again. Yeah, it was horrible.
I'm not even talking N95s. I'm talking about a little surgical mask. We didn't even have N95s at that point. That's another podcast, right? That'll be another podcast.
Yeah. What department were you working real quick during that COVID era?
So I was in when it broke out an emergency room, but I was working as not an emergency nurse because I was on a travel contract. They had basically brought us in, travel nurses, to deal with the boarders that were waiting to go up. But we were physically like right there. We were taking up one of the main pods in the emergency room, and then it broke out.
Yeah.
I did that, and then I did a couple travel contracts for straight just COVID. Yeah.
That's great. Single guy, no familial responsibilities, picking up contracts. I even wish I had known earlier. I would have done local contracts, but
not single though. Not single. She was my girlfriend when we were doing that, and then throughout. Actually, that's where the COVID pay went. Engagement ring, and then now we're married.
Oh, there you go.
Yeah.
All
But
right,
still bouncing around. But nothing tying me down like kids or anything.
Yeah. I did local for a while. I did 2 years in Queens, and then we bought a house out in Eastern Long Island, and I'm actually about to start a staff position for the first time. But not a good swing shift, the 2 p.m. to 2 a.m. shift, which is not fun, but you got to start out somewhere. You have the home health hustle.nurse. That's your Instagram. The hustle part is so true in this field. If you think you're going to go into nursing the same way maybe a teacher presumes that they'll get hired at a school and get tenured, that's really not what nursing is about. Like, you may be a nurse for a while, but you're going to bounce. You're going to try to get the shifts that you want, whether you want to be at night shift or you want to get the day shift or swing shift is working for you, or maybe you're going to work per diem at 2 places so you can work more but keep more of your money, but now you don't have health insurance, so will you be on your spouse's, or maybe I'll just get a permanent position and then another per diem position. It is a hustle. It is a hustle. You have to have that mindset if you're going to be a nurse.
Yeah, you really do.
I didn't expect that when I became a nurse. I expected something a little bit more cushy. I probably got a false impression from being a corpsman because it was a more masculine version of medicine where, and this is not a dig at civilian medicine, but it's just a little bit more, we're going to attack the illness. We're going to attack death. You get that in the code room. I like that about codes because we're attacking whatever is
Sure.
hurting the patient, and we're not going to stop until we have to stop. But for the most part, I find more and more I'm a task manager because we're drowning in patients and there's just not enough people hired. So I find like I'm just trying to keep my chin above water. But even when I can utilize my critical thinking and collaborate with the physicians and things, I still feel more like I'm outside the group sometimes. In Navy medicine, certainly, whether you're with the Marines or not, you're very valuable. You feel empowered. You're learning these skills that are way beyond a paraprofessional, and it's great. But when you become a nurse, you realize, I remember I was in a code in the early days, and one of the things I was trained to do as a corpsman was to do a crike. And we actually had to do a crike.
Nice.
And the physician was, quite frankly, he was screwing it up. And unfortunately, we lost that patient. And I just wanted to like get in there and be like, grab the hook, hold it down, pull this. But I can't. I'm a nurse. I'm not allowed to do that. And he certainly isn't going to let me do that. And this stuff like that happens on occasion.
Well, and that if you did that, he'd pull rank and bad news.
It'd be bad news. Hey, folks, if you like what you're hearing, go to my website, www.mynursedad.com, hit subscribe. If you go down, you'll run to my Instagram. You can subscribe to that. I try to funnel people to my YouTube because there's just more content on my YouTube. And you'll find the YouTube icon on my website. Again, that's mynursedad.com. And I'm speaking with Scott. His Instagram handle is homehealthhustle.nurse. Are you also on TikTok?
It just started.
Yeah.
I'm learning because I'm on YouTube, I'm on Instagram, and I'm on TikTok, and that one I'm learning, which should just be Home Health Hustle Nurse. I don't even know my own handle. That's how fresh it is.
And there'll be links down below for those interested in that. I certainly recommend it. I'm jealous in a way because you sit in your car and you give these educational videos, and they're pretty popular, and I'm happy for you. And I look at you and I'm like, I got to do some more educational themed things. People don't want to hear me just talk randomly. I need to have a...
Some people do, though. I'm going to tell you, the people who go on YouTube want the longer form content.
Yes.
So I have, I mean, I don't have a lot of that because I don't have a lot of time, but that's what they're looking for on YouTube. Instagram, you've got about 3 minutes or less to figure it out. And then
probably like TikTok's like 15 seconds.
Exactly. You sneeze and it should be over. TikTok is like that, but you're almost right on the money, 15 seconds, and then you better have said what you said and you're done.
So I want to steer the conversation to more topical.
Sure.
We were speaking about this before. I think it came into law in New York. They call it the physician-assisted suicide. And a lot of people have opinions on that. Back in the day, it was legal in 4 states, including Oregon. And it's becoming more popular. I've seen people suffering. And if that were happening to me and I couldn't take it anymore, I would probably be interested in something like that. Some other people have different opinions, but it's here in New York. And I just wanted to go over what their requirements are, and then we can go from there.
Can we clarify for the viewers exactly, like we're talking, was physician-assisted suicide, correct?
Yeah, this is physician-assisted suicide in New York. I'll just skim through it. You have to have a mandatory mental health evaluation, obviously. You have to be within 6 months. It's a prohibition against anyone who may benefit financially from the death of a patient. I really like this part. So nobody has a financial investment in your death. Maybe you're an artist and they own your music or something, and now you're something like that.
Like, yeah, we're going to sign off on his death so we can start making, I like that clause too.
Although it's interesting because I know there are cases where, and I'm not sure if here in the U.S., I know in Canada and overseas where someone has Alzheimer's or dementia,
sure,
and it's somebody had to sign off on that. I thought what was really interesting between what has been happening in the U.S. and Canada, because in Canada, the physician can directly euthanize a patient. And I'm not sure what's going to happen now, but in the past, in the states where physician-assisted suicide was legal, the physician handed you the stuff and you had to do it. I remember watching a video where a woman, she had a terminal illness, she was on the younger side, but she decided in Oregon to do this. They gave her the stuff to take home. That kind of sets better for me. I don't know how I feel about the idea of the physicians doing it directly. In Canada, there's some physicians who have euthanized over 400 patients in a year. I read that it comes down to 81 physicians euthanizing about 15,000 people a year in Canada. And I don't know, that to me mentally, that if I were a physician, I don't know how I would feel about directly injecting feels when someone gets the death penalty. And I don't know how I would feel about that. Where in the United States, it's at least up until now, I'm not sure what's going to happen in the future. They provided you the means to do it and you did it on your own. How do you feel about that?
So I think along the same lines of as what you're saying with it's almost going against the Hippocratic Oath, right? That doctors have to take or physicians have to take. Okay, it's still a treatment, but it's an ending a life treatment. So I don't know, and that I would be, as a physician, comfortable doing that for patients. Now, I imagine that not every physician is mandated in Canada to offer these services, but if they're directly pushing the drugs, they're the ones that are ending the life or what have you. I feel like there's probably a pretty big ethical weight that goes along with that. And I would be more in favor of what happened in Oregon. We might have seen the same video of that female.
Yeah, it was a few years old.
Yeah. I think that just for the mental health of physicians and their practice, I'm not a huge fan of how Canada does that. I would think that the better option would be having and it gets sticky when you have someone with dementia, but like having, I want this, I'm going to take it, it's on me because I'm physically taking whatever drug to end my life. Now it's on me. That guilt is not on the physician or the pharmacist or whoever that would be pushed. If a person is okay with that, if a physician is okay with that, maybe, but I just don't see long-term how that would be mentally healthy.
Also the perception in the public, we were talking about COVID, and there's a lot of lingering remnants of that. I think a greater distrust.
Yeah.
And once you cross that line where now physicians can directly, I don't even know what the language should be. I want to say terminate, but that's euthanize. In my head, I'm like terminate, euthanize. I'm sure you've had your fair share of DNR, DNI patients, and it's decided, and their blood pressures going down and the heart rate, and you're giving them morphine to make them comfortable if it seems like they're in pain. But there's a natural process. Like no one's going in there and injecting somebody with something that will cause them. So that's a whole different thing. Go ahead.
I think the concern there is if you're enabling physicians to do this, there's a concern with people that are poor, their quality of life sucks. They keep having these comorbidities that are driven by their socioeconomic status. Okay, now are you just enabling this to kill off the poor?
So and that goes back to the Canada case, the suicide of Sophia, who's not alone in this case, where, to sum up, she had a condition where she was hypersensitive to things, smoke and mold and whatnot. And she put in for specialized housing, but couldn't get it. And she became a candidate for the physician-assisted suicide. And that's what they did. Like you said, because once you go there, now you're opening up a doorway and
setting a precedent.
And it could feel like that, and it could be perceived like that. And in this case, there's a lot of questions. Why did that happen? She didn't have a terminal illness. She was just seeking specialized housing. And yes, maybe she was suffering so much that it was a good idea, but it was also because you couldn't find her housing. Find housing.
I think reading that, it's like all she wanted was better airflow. It was something pretty basic.
Yeah. It's 2026 now. I think we all live in the real world, even in medicine. A lot of it's about the numbers. It's about what's cost effective. Is it more cost effective to euthanize somebody than to work and get them the specialized care that they need? That's a horrible conversation to even have. I would do everything I can for the latter. To euthanize somebody over their socioeconomic status is abominable. The easiest way to get around something is to legalize it and then come up with all of these shortcuts around it. Yeah. If this becomes the law of the land, how quickly are they going to be able to put amendments in there in case of this or in case of that, or if this happens? And so that wasn't the original intent, but now you've legalized it and you've created all these loopholes. That's been my experience. So you want to get around something, legalize it. I don't know. That's just my opinion
Well,
there.
and we're modern medicine, right? Well, people are living a lot longer because of all the advancements we've made. But oh, wait, now that we're living a lot longer, we can't afford to house them or take care of them or anything. So
Yeah.
we're up against that. I guess it's like trying to balance the fulcrum where, yes, we're living longer, but where's the quality of life? And now the cost associated to take care of them. And how do we balance that out and make it work?
And you can't underestimate someone's pain if they're
Nope.
going through chronic illness. I spoke to you about, I had an ex-girlfriend whose father, he was only like 61 or 62. He's a retired police officer, but he still worked in the police department. And he had some rapid form of dementia. And they told him it's not going to be a gradual decline. It could just drop 1 year and he already was moving in a certain way where you could tell he was having trouble. It was already setting in. And again, he had a condition where you can't expect a predictable gradual decline. And he outright told his family, I'm going to shoot myself in the mouth. I'm going to do it now. And was very assertive with that. And they wound up buying property in Europe so that they could take advantage of, I can't remember the country, but their euthanasia laws. And because you can't just become a citizen easily. But if there was some kind of loophole where if you bought property, any kind of property, you can take advantage of the health benefit that they have. And so they did that. And he was adamant, like he was not going to go through dementia and be what he perceived as a burden on other people. And I'm not advocating for this, but that was his experience and his decision to do that. I had an uncle, for example, he retired, he bought a camper. His dream was to travel around. He did a lot of things with veterans. He wasn't a veteran, but he did a lot of things with veterans. And a couple of years into it, he had diabetes and he had all these chronic illnesses. They basically told him, like, you're not going to be able to drive anymore. And he settled his affairs and he went to a hotel and with a gun and he ended his life. The day of, he sent me a book on Amazon, the book written by Arnold Schwarzenegger. And the problem with that is I don't know what could have been available to him. But when you have people like the ex-girlfriend's father, if they were to kill themselves, people don't realize that when someone commits suicide, all the people around them they're more likely to go down that path as well.
Yeah.
For example, my uncle was very close to one of my cousins who has a chronic illness, and she loved him, and she's been very affected by it. And it is not far-fetched to be more concerned about her safety based on his decision to just suddenly go into a hotel room and end his life and send people gifts on the day of, probably the minutes of, on his phone. You don't want to put people in that position because now they're harming everyone around them. If that was happening to me and I'm like, to heck with this, I'm going to off myself or commit suicide. Now my kids are more at risk to commit suicide, statistically speaking.
3 times, right? Three times as
right?
like,
That's a horrible legacy.
Yeah.
That's a horrible risk. And perhaps if it was legal in the state that he was in, or we're able to converse more about this because it's legal, if somebody was in that position, they would have done it in a way that was more comfortable for them and for the people around them. That's what I'm getting into.
give the family and friends and everyone closure. This is my choice. This is why I'm doing it versus abrupt. Because there's an element of concealment in that. I'm going to a hotel to do this because it's not legal. And I can't tell anybody about it because of what it is. So now I'm going to go do it. And then, like you said, the reverberations socially with family and friends is, I don't know if I'd call it harm or definitely damaging psychologically in some manner.
You hear, especially from guys, where, well, if I found myself losing my mind, as they say, or if I suddenly can't walk, I'll just kill myself. And a lot of people, they don't mean it, but statistically speaking, some people actually do it. And they're putting their loved ones in harm's way if they commit something like that.
Isn't that the highest proportion? Like men over between 50 and 80 or something like that? They're the ones that actually follow through with it.
Most of the time they're using a firearm. There's no cry for help if you're aiming a gun at yourself. Maybe you'll miss or you'll hit something, and I don't know. But yeah, there's not much room.
On that note, though, a lot of the trauma transplant units I worked on, I had a lot of patients who missed when they were pointing and their lower jaw was gone. And I took care of a lot of people like that. So you're right.
I read an article of a young girl who did it. And on the surface, she seemed like she had a great life. She was like a beauty queen. And one day she shot herself in the face, but she wound up like needing a face transplant. She survived it. And
Awful.
that's
Yeah.
heartbreaking. But yeah, so for me, there should probably be an outlet for everybody, whatever they're going through a chronic illness, being in chronic pain. It changes your mindset. I do support this program for people who may need it, but I'm suspicious because now it's entering the government sphere and regulation and law. And I'm not one of those people that thinks my politicians are always working for me, especially when big money is involved. What's going to happen there? The private sector will get involved at some point.
Yeah. And especially like the laying out, you touched on this earlier, laying out the parameters of, okay, what are the steps? Because I think we have Oregon to model. Were they the first ones? They're the ones that come to mind. We have Oregon.
Or one of the states. I know there was only less than a dozen, less
Sure.
than half a dozen, but Oregon is the one that I remember.
Yeah, that
Because of that woman who brought it home. Yeah.
I think there might be another state up in the Northwest, but having that as your model and which parameters, is it working, is it effective, and so on. I would hope that when they're introducing this law in New York or anywhere that they're going to do it, that they would go off of the research that's already there and not just, hey, what can we do with this? But again, like you, I don't trust politicians very much to do anything.
But what's interesting too, going back to what we said was the difference between the U.S. and Canadian model. And
Yeah.
again, that's up until now, because I don't know how it's going to change. Whereas the Canadian model, the physician euthanizes you.
Right.
And the U.S. model that I know, like in Oregon, when I say, if you don't say Oregon, people from Oregon are going to be very upset. But
That's how you get
I had a
comments from people from Oregon.
Yeah. I have a friend from Oregon, and I'm like, how's Oregon? But no, but it's, if the way is to, like, the American way is to give you the means to do it,
Yeah.
and you go home. To me, if you really truly want to do this, that seems the more appropriate.
Yeah. Again, the weight of having that decision, or the weight of executing someone, because that's what it is, that goes back to like just the psychological health of physicians doing it. I do support it if the right parameters are put into place. And I don't know, physician wise, everyone makes their own choices. I don't know if me personally would be comfortable as a physician having that kind of power.
I was even thinking from the nursing perspective, because the physician makes the final move,
Yeah.
but the chess pieces are laid out by the nurses. So would it happen in the ED? Would the person come in to the emergency department to get it done? Will the decision be made while someone is on the floor? And now there's going to be a prep for this, and you start getting into that. We're used to like a DNR, DNI patient, but now you have someone come in who might walk in and sit there and come into the room, and you do vital signs, and
Like
maybe they need some
teams
morphine.
within a hospital that would be responsible for setting this up. You mean a death team or something?
I don't know what to call it. I would imagine it's more like a rapid response team that comes in at a hospital, where if they're called to action, then they show up, but otherwise they're doing what they do, their normal routine. But you know how it is and the way things are.
Yeah.
I could totally see myself as an ER nurse and someone coming in under this new law and walking right in saying hello, because not everyone with a terminal disease is in bed incapacitated. And the Canadian model, I don't think it's in effect, but there's conversations about expanding it to pediatrics, which is a whole nother thing. I had Nurse Erica on the podcast. I learned about pediatric hospice, and it was really quite endearing, because in America, if you're in pediatric hospice, they still allow you to do everything you can to try to get your
Save your
kid
kid.
well. Even alternative medicine, they will not stop that. But it's in place within pediatric hospice, so that's also available. And that's what I think about. But to expand it, to make a decision, which could only be the parent's decision, again, I don't know how I feel about that. I would need more time.
Yeah, I actually watched that podcast, and I thought it was very interesting to learn that with pediatric hospice is a thing, because I never even considered that, but of course it is. To have that be available, I'm glad it is. I'm glad it is set up that way, because I don't know if it was you or her that said, who wants to be the a-hole that tells their kids that, no, you can't do everything possible, but yeah.
Yeah, she said that.
Okay.
Yeah, it was.
Remember that.
I didn't even expect that part of the conversation. I knew she was in pediatric hospice. To me, that's what medicine is. That's the best of medicine. And when we start dabbling into euthanasia, I'm in uncharted territory.
Well, a lot of people are. Well, the whole goal is to save lives, right? We're always doing that, but now you have to factor in quality of life, and that's huge because if you don't have any quality of life, okay, where do we go from here?
And I think it's also because a part of me, and I'd love to get your opinion on this. I've said this on the podcast before, that I think medicine it's like a conveyor belt, and it needs to be like that because it keeps things moving. But when you identify a patient that needs some sort of specialized care, you take that patient off the conveyor belt. And sometimes you're staring the system right in the face. A lot of times the physician or PA, whoever I'm working with, they agree with my assessment or that we need to do something different based on a result. But sometimes you do get pushback from the system and they're like, no, put them back on the belt and keep going. And now you're concerned about someone slipping through the cracks. And so now when you introduce this power that can determine, I don't know how to describe it. It's like I'm already suspicious of an element within the field. I have to be like, and it's only because it's based on money.
Yep.
That
Insurance.
yes, insurance and pharma, and it almost sounds cliche, but they run healthcare. And now you introduce this element where, okay, people can decide on euthanasia, but now you get health insurance involved, you get money involved. I guess I'm jaded. I can just see so many nefarious fingers inserting themselves into this.
So the vanguard against that would have to be a very robust ethical board that has a lot of power. The only way to do this correctly would be to have that. And with them being above the money and everything, if they come in and say, no, we're not doing that, etc., they have to stop. And I'm in line with you. I can't stand insurance and how we disenfranchise so many people just so we put money in others' pockets. You should not be able to profit off of patient care and patients in hospital beds, the sick, the dying. It's one of my hot button issues, but I'm not going to do that on your podcast. But I agree with you. You
go anywhere you want.
No,
I'm okay.
I have a
with
lot
it,
of
but,
envy to anyone who is making money off of someone sick in a hospital bed and cutting corners just so they can profit, the detracting from patient care. And there's some very guilty hospital chains that are for profit. I know the non-for-profit hospitals, they're not.
they can be bad too.
They
can be bad
exactly,
too.
but there's some, and I've worked for one of the biggest chains and I saw it firsthand, but I'm not going to get into that. But I'm with you.
Yeah, I get it. It's a business, but there's a way to do business. And then there's just cutthroat policies and clearly not giving a hoot about the patient. It's like anything else. Like when you had the subprime crisis in 2008, the couple sitting across from you can't afford this and you make the deal anyway. And then you get away with it. It's just stuff like that just bothers the heck out of me. Capitalism works, but when it's so ruthless and just no accountability, it could be terrible.
Exactly. Accountability. Was it Greenland or Iceland that let the banks fail and eat it because they gave out those loans to get into a financial thing? But the U.S., and we ended up bailing them out because they're too big to fail. No, they made these crappy decisions and now they should eat it.
Yeah, I don't believe in too big to fail. We will adapt and overcome, as the Marines say. If you are doing the wrong thing, you don't deserve to be in business. We'll get over it. I don't think people want to keep afloat some huge corporation that's not doing the right thing, and we're just bailing them out with our tax money and not getting anything on return. I think people would just rather...
We're paying for their mistakes. Yeah. What the heck is that?
I know.
But that's a sentiment that can be applied to healthcare too.
Yeah. What do you do to reconcile some of the things, people slipping through the cracks or just some things that are just not being done? Do you have your shifts or your days where you just look in the mirror and you're like, man, this is not a day I expected to go through?
Like big crappy situation for this patient.
Yeah. Not to cut you off. Like when someone comes in from a nursing home that I know is like 10 grand a month and they've got a stage 4 in their back, and you just know it's because no one turns them over. No one even looks.
No, they're too busy. Yes,
well,
agreed.
Yes, there's a staffing problem. It's horrible, but you are charging the families 10 grand a month.
You can make on a pure unit.
Yeah.
Oh, you have 10 patients. You're pulling in a monthly $100,000 and you cannot afford to. I don't buy that. You cannot afford to hire staff for that. I don't buy that at all.
I'm not trying to villainize staff. You have one nurse for 50 patients sometimes.
No,
and then you have CNAs for 15 to 20 patients. It's the system not hiring enough,
correct.
not the incompetence
The,
of
the
healthcare
owners,
workers.
yeah, because anyone that's been in that situation, or maybe they've been a family member in a room, the staff don't have time to do anything. Like the nurses come in, they throw the meds, or if you're on the floor, depending on if you're in a skilled nursing facility, yeah, maybe they have 40 patients that need to get turned. For one CNA, that's insane. But going back to what you had just asked in home health. Oh, were you going to ask some?
No, continue
Okay.
what you were saying. You thought.
So going back to home health, how when someone comes in that we get an admission or we get a patient that see these things where they have fallen through the cracks, there's a lot that we can do at our disposal to stymie or do a damage control. Starting with education, maybe the family's taking care of grandma who's 85 and she's bedbound. They don't know about turning them to prevent decubitus ulcers,
Right.
or you get,
Or they don't have a specialized bed, like some beds
yeah.
where they have sand
yeah.
for the mattress. And
So that's actually going to be the ACE that we pull in. So there's some education, or if it's like congestive heart failure, hey, stay away from salty food. Sometimes it takes repeated education that they don't have time to necessarily do in the hospital. And if it's a patient that has a new diagnosis, they're not going to know a whole lot. But when it comes to things that are more socioeconomic, the white knights that we call in are the medical social workers. So they'll come in and they'll assess and provide patients. Maybe there's a benefit, the community resource, something through Social Security, something that the county does that can help, whether it's food or so on, that will help with that.
Because you're on your own. You're in someone's house. You don't just have. Sorry, hold up.
No, you're good. I think I have these backwards.
Sorry about that.
You're all good.
Let me just get a drink. Man, I am under it. I'm under it. Oh, sorry about that.
Tamiflu.
All right. Thank you to my youngest daughter for getting me sick.
Oh, yeah.
Yeah, so you were definitely on your own, but part of that is the appeal, right?
Yeah.
Not that someone is infirm or suffering, but that it's up to you to make that decision, and no one's standing in your way in that moment. It's just, who do I got to contact? I have to set it up.
Yes.
They have to go on your word because you're not there. And I think sometimes that's the best thing for a nurse.
Yeah.
Let me come down and look at the patients. I'm telling you, just do this thing.
Face value.
I need it. I need it now. It's going to take you 2 hours to even get down here. And then by the time you put in the order, like, that's a power to be able to.
Yeah. And thankfully.
Hold on 1 second. I'll make that look nice.
That's okay.
Oh, this popped out. Oh, man. I think I'm getting sicker right in front of you. Hold on.
No
one
bueno.
moment. Sorry about that. Still going to get to the gym later, though.
Goggins.
I'm sorry. Yeah, Goggins. What were you saying?
You're 100% right. Fortunately, we work with some really great physicians where it comes back to teamwork. You're part of the team. You're their eyes and ears. Hey, this. And I do want to make a statement in that sometimes nurses have to do, especially in home health, reports to APS to get patients benefits they otherwise wouldn't qualify for. It's not so much as a punishment.
Go into detail with the APS.
So APS is Adult Protective Services. It's like you have Child Protective Services. You also have Adult Protective Services you have patients with dementia, or maybe they're up there in age. They can't fend for themselves, for lack of a better term. Nurses across the board are mandated reporters for certain conditions. So
of course,
if you suspect neglect or different things, you're mandated to make a report to Adult Protective Services. They'll come in, they'll investigate. And it's not always punitive. I had a patient, this elderly lady, who really needed someone because she had dementia, but she kept getting up and falling.
Right.
Her only caretaker had a son who was special needs, and she had to work her full-time job to be able to afford both her mother and her son housing. So I did an APS report because, the patient's sustaining wounds because she's not able to be cared after, but it's not any fault of the family.
Yeah.
So we do the report, APS comes in, and sometimes they'll have more to offer the patient.
She's just taking on too much responsibility.
Yeah.
It's to the detriment of everybody.
Yes.
Yeah, that context is very helpful. That's worth thinking about. It's not just always, we're going to take your parent away, or we're going to take your loved one away.
Right.
It's just, you need support. I saw something similar, with Child Protective Services, because the father who was raising his 17-year-old daughter was a drug addict, but an occasional. He wasn't consistent with it.
Sure.
And he was going through a lapse. And his daughter, who had a permit, she drove him to the emergency department. And if you have a permit, you can only drive with an adult who is responsible, not someone going through withdrawal and all that. And they called Child Protective Services. And I thought, what are they going to do? Are they going to come in and take her away or this or that? And they basically scheduled for an aunt to pick her up and to just be more involved during this time. It wasn't some iron fist coming down.
Sure.
I thought that was interesting.
Especially if she's doing transportation for her dad in the first place. Yeah.
Yeah. And it was a troubling situation because they were about to get evicted from their apartment. He's lapsing, the money's not there, but they reached out to the family in a way that clearly she and the father weren't doing. They got her family more involved in her situation, basically for her. And that was their involvement. It wasn't, oh, we're taking you away. It wasn't anything like that. That's an interesting perspective. Oh, I feel okay now. I'm sorry.
You said it out.
I'm usually so... I feel like you're watching me at my worst for this one. It's going to be a great podcast.
Yeah.
Usually I'm not suffering so much behind the scenes.
No, we're nurses. We're susceptible to things too, right? We still get sick.
Yeah. I work at several hospitals going back to staffing issues, and I'm not going to work there much more, but this is a very small hospital and it should be, I won't say a cakewalk, but it should be a lot easier than it is. I've worked at trauma 1 centers, where you get your break and you have your 8 patients here in New York, and it's very busy. There might be 95, 100 patients in the entire emergency department. And I work at this very small hospital, and there's no conversation about nurses having breaks. There's no attempt to break nurses. I'm emailing a sheet today so that I get paid for that break I didn't take, but you're so oversaturated with patients. For example, I had a patient who had 2 bags of blood. I infused 2 bags of blood, and the hemoglobin was still 5.2, quite critical. And I couldn't even get back to her for an hour. And the nurse next to me had a patient come in, numbness radiating throughout his body. He couldn't get to his patient for 3 hours, 3.25 hours. I had 2 patients on the board for over an hour that I couldn't even get eyes on, even though their orders were already done.
That should terrify people. People don't know about this.
I've never seen it so bad. I haven't worked there in a while. Then I came back. It's even worse. And I told my wife, I'm like, I really can't work here. It's dangerous. Yeah. It's actually very dangerous because I'll see patients coming in with a possible stroke symptom. There was nothing done in triage. I told my wife, anything could happen. I'll look on the board and they'll just be, because I'll be in like a room. I had sepsis, so I was in the room for 10, 15 minutes. And then I come back out and there's a chest pain, like active chest pain patient that was waiting 20-something minutes. By the way, the system I was using, I won't say its name, they switched over to this system. So I have a sepsis patient. I put in the line, and you have a rover, this little phone to scan everything. Won't let me scan the meds until I go back to the computer and put in the IV line in the computer. I can't override it. Can you imagine that?
Yeah.
Because with sepsis, my whole big thing is I want to start the antibiotic as soon as possible because technically you're not managing sepsis until the antibiotic is flowing. And a lot of people put the fluid and then the IV Tylenol or the Aframev. But really, sepsis is not being technically fought, I heard, technically or legally until the antibiotic is flowing. So I'll do the first IV and I put in the second IV and I'll do the fluid and the Tylenol on one arm and I get the antibiotic on the other arm and I scan it because I wanted to scan in that like that antibiotic is flowing now. And I'm in the room and I got PPE on and it won't be scanned. It won't let me. So I have to take everything off, get to the computer, set up the IV, put everything back on. I'm like, this is ridiculous. So on top of all that at this facility, I'm dealing with this issue.
That's insurance and litigation getting in the way of patient care, and it's a detrimental thing. And the other thing I was going to say is that if anything happens at that facility, it's your license that's on the line. HR is not going to redonda vot. That's all I got to say about that. They will throw you under the bus.
Every time. I want to say to nurses out there, especially novice nurses, if you're at a facility that won't even talk about breaks, there's no attempt, you get out of there. It doesn't surprise me because I did a different contract at another small hospital, and it was the same thing. And it's not a coincidence that you have such a unsafe work culture and a leadership that doesn't even talk about breaking you. It makes perfect sense.
They got their MBAs and everything. It's very telling because all of your upper management and admin, they're not clinical unless you're the CNO or CMO of the hospital. And that kind of permeates down to how things run, like why you have to do that.
But in the ED though, like you have the manager and she's a nurse, or they're a nurse. To me, it's so easy. You just get one more nurse on the floor and then use the swing shift nurse to break everybody. It's just so easy.
Yeah. Or they have specialized nurses. That's their entire job. You're a break nurse.
Yeah. And a lot of hospitals that I work for, that's what they do. I've never seen it so bad. And not just that, but people waiting to discharge. There was a woman who had I'll use the lamest term, nosebleed.
Yeah.
And it was managed.
Yeah.
And it took me 3.5 hours to get to the discharge paperwork because I couldn't justify it. I need to hang a third bag of blood. Hemoglobin of 5.2 after 2 infusions. I have chest pain. I have sepsis. When you have that much, and there was even more than that, I just can't discharge. I can't ask the doctor to finalize the paperwork and go to you and explain everything to you and then get the rover. I can't justify that when I have such high acuity patients, and they just piling on like that because they're just grossly understaffed. And so I had a guy who came in with retention. He had a part of his colon removed.
Yeah.
I did a bladder scan. He had about 700, 800 milliliters of urine. It took him into a room. I did the textbook case of the Foley catheter. I love it when it's easy. But it took 4 hours to get him out of there after everything was done. He's just laying there. And you want to get these people out. But in this particular case, there were patients waiting for an hour, 2 hours. In my buddy's case, 3 hours and a quarter in the ED, waiting in the ED for the orders to be fulfilled, to take the blood work, to hang the first meds. It was crazy. It was nuts. And so just a warning to novice nurses out there, don't put up with that because they will throw you under the bus.
They will. And he or she is a novice nurse. Obviously, they don't know what they're doing. Yeah, so it's an easy way out. And the sad thing is those patients that, it took 3 hours to get them out. And I don't know whether they were aware of everything else you were doing or not. They're going to get the little Press-Ganey thing and fill out, no, that I had terrible.
No.
How is that a fair measurement
like
on anything? Hey, we fixed your nosebleed. High five. Get Press-Ganey out of there.
Or just because the doctors are so inundated, it's okay, we treated sepsis.
Yeah.
We did vital signs again, no fever, everything's working out. And then 6 hours of just like, I have nothing for you. You're asking me, now the doctors change shifts. There's a new doctor. They got their own. This isn't a comment on the physicians. It's the facility and the way everything is managed. That from top to bottom, it's just nuts.
Yeah.
It was nuts at this particular place. And they wonder why so many nurses leave the field, unfortunately. And why, again, the home health hustle, the word hustle, it's like a lot of times nurses are just trying to go somewhere else because they can't breathe. They just can't function. They don't feel good about themselves. And
shift too.
It's ironic too. I find that some healthcare providers that start to loathe the very patients that they're supposed to be caring for, they're the ones that kind of climb up the ladder because they don't want to be in direct patient care. But then it's sort of bitter,
sad but true.
Kind of it transfers over. Like it's directed at the nurses. That attitude, and it's a challenging profession. Most of my experiences are good, but you have to be cautious. You're the fall guy. You're dealing with people who, for some of them, it's the worst day of their lives, and the profession is constantly changing.
Yeah.
But Scott, I want to thank you for coming on the podcast.
Sure.
Thank you for enduring me as I literally get more sick.
Before we wrap up, can I make one plug?
Yes, please plug.
I picked up this really awesome book recently called Isabel Learns to Share.
Oh, snap.
And you guys should go out and get this. If not for anything else, I don't know what page this is, but there's a hilarious mouse surrounded by a cat.
Mouse, yeah.
This is my favorite page. But you guys should really check it out. Just order it. You won't be disappointed.
Oh, I appreciate that. I made that for my daughter. It was a lot of fun to do that. Written 100% by me. I'm actually writing a book now for adults, writing about the medical encounters I've had, both in the military and in the civilian world, that have shaped me. You sound like you have a fantastic book that you need to write. I think if you were to exclusively focus on your journey, get some of that ER in there, but really the home health stuff, I think that's fascinating.
Title will be "This Sucks," and then you'll have a conducive.
If you can leave me out there, I will buy it. I appreciate that. There's a lot I want to do with the channel. I feel like I'm still in my infancy. It took a while to find my voice, and then because you're just so busy, it's hard to
Yeah.
make all the content that you want. But you're actually an inspiration for me, seeing what you do and the instructional content that you have. I like just how you just chill and you say how it is with your experiences.
I try to put stuff out there that's fruitful and entertaining. So I'm glad people like it. So thank you.
We got to motivate each other for the weight loss or the
Yeah.
toning of the muscles or whatever the language is going to be. Yeah.
Under
Well,
12.
you said
Go ahead.
no, you said under 12%. Yeah.
12%, between 12 and 15.
I'll take 15%, man. I'll take 15, even 20 at this point. But yeah, when you texted me or you're like, oh, I'm just down deadlifting right now. I'll be ready in a little while. I'm like, oh yeah, I got to get to the gym myself.
It helps to have a gym in your garage.
I do.
Oh, okay.
And it's so cold here though. It's freezing.
Yeah.
And it doesn't have a sauna.
Oh, touche.
Okay.
That's the one thing I miss from the dry sauna. The one thing, well, a red, but yeah, that's like the one perk of a bigger gym. You have those rooms.
Yeah. I'll be keeping in touch with you. We should do a live at one point. I want to ask you, I saw that you did a live with somebody who is, seems like they're very much into diet and exercise.
Yeah.
I thought that was great. I don't even know how to do that. But yeah, let's definitely keep in touch. Let's motivate each other.
Sure.
And thank you for what you do, fellow Navy veteran.
Yeah.
Yeah, yeah. Thanks a lot, man.
Yeah, no worries. Thanks for having me.
Thanks for coming on.